We are good to start.
Good evening, everyone. This is Dr. Manvitha, Consultant Emergency Medicine at Yashoda Hospitals, Hitech City. Welcome to the online webinar sessions hosted by the Department of Emergency Medicine, Yashoda Hospitals. Today, we are here to discuss about dermatological emergencies. Many people think that dermatology is not an emergency, but yes, there are few dermatological emergencies. I would like to invite Dr. Satya Pandragi, Consultant Emergency Medicine at Yashoda Hospitals, Malakpet. Welcome, ma'am.
Good evening, one and all, and thank you, Manvitha, for your introduction. Yes, like as you said, even I was a person who used to think that dermatology is not an emergency until I have actually seen those and dealt with those cases. So, if you're all ready, shall we start?
Yes, ma'am, you can start.
Yeah, thank you. So, the dermatological emergencies that we are seeing in our day-to-day life in our EDs. Just a minute.
I'll put on person.
Dr. Priyanka?
Yeah, give me one moment. There's some issue. There's some technical issue.
Okay.
Yeah. So now can you see my screen? Can you see my screen?
Yes?
Yeah. So coming to our emergencies, day-to-day EDs, our dermatological emergencies that we are dealing with, they range from small allergic reactions to anaphylactic shocks to a wide variety of generalized skin infections, or we can call it skin manifestations. So today I'm going to discuss about one of those which range from which is Manvita, I'm
Yeah.
sorry for this. Can you just ask somebody to share the screen because there's some technical issue from my side?
Sure. Shanti, please share the screen.
Yeah. So okay. You can proceed to the next slide, please. Yeah. So there are multiple emergencies dealing with the dermatology. And today I'm going to discuss about spectrum of these, which include erythema multiforme spectrum. There is a lot of confusion with the nomenclature of erythema multiforme spectrum. And in this, I'm going to discuss about erythema multiforme minor, erythema multiforme major, Stevens-Johnson syndrome, and toxic epidermal necrolysis. Next slide, please. Next slide. You can change the slide. Okay. So generalized dermatological conditions we come across are exfoliating erythroderma, staphylococcus, scarlet skin syndrome, streptococcus, and staphylococcus toxic shock syndrome, meningococcemia. All of these we deal with in our day-to-day EDs. And now among these, I want to discuss about erythema multiforme. So erythema multiforme is a spectrum which includes erythema multiforme minor, erythema multiforme major, which is also known as Stevens-Johnson syndrome that we come across, and also toxic epidermal necrolysis, which is shortly called as TEN. Next slide. Yeah. And the next one, please. So the classification basically in this is mainly based on the extent of an involvement of the skin and also the mucous membranes. The extent of the disease, the mucous membrane, and the epidermal detachment are the main components which easily classify these diseases. So where a patient presents with so and so symptoms, we can differentiate them or classify them based on these things. First is it a localized reaction? Is it a generalized acute inflammatory reaction or a multi-system involvement which is life-threatening and toxic? Next slide. So as you can see in this slide, this is erythema multiforme major, where a small papular eruption is seen on the hand of this patient, which has, the distribution is mainly in the acral region with target lesions, and there is erythroid lesions mainly seen on these. The papules which are seen are only localized and they are present only on this hand. So this patient, when he comes to the ED, you can first reassure him and tell him this is a localized reaction. The dermatological manifestation is due to so and so reason. It can be causative organism, some infection, a drug which he's taken, which he or she has taken recently, or anything. First, ask them to stop that, check the vitals, reassure the patient, and then you can tell them they can follow up in the OPD. So if they ask you for treatment, then we have to discharge them home with a dermatological consultation and a steroid. Next slide, please. And the steroid that we should consider is prednisolone, ideally, or an equivalent one you can consider 60 to 80 mg. And along with that, if the patient has a lot of other symptoms like pruritic rash, itching and everything, you can go ahead with diphenhydramine 25 to 50 milligrams 6th hourly. And usually these patients may have herpes simplex along with it. And if at all it is present, go ahead and treat the herpes simplex virus as well. Next slide. So now there is a lot of confusion with the nomenclature of erythema multiforme major and Stevens-Johnson syndrome. So erythema multiforme major, Stevens-Johnson syndrome, and toxic, the TEN, all of these are basically similar kind of clinical manifestations. The major difference or the differentiating factor, as I discussed previously, is the epidermal detachment. The epidermal detachment of the body surface area, along with the mucosal membrane involvement, mainly differentiate these three. So the first, erythema multiforme major and Stevens-Johnson syndrome. In these, the epidermal detachment is less than 10% in erythema multiforme major and more than 10% in Stevens-Johnson syndrome. There is another manifestation where, Stevens-Johnson syndrome has been classified even further because of its depending on its involvement. One is where 10 to 30% of the skin involvement is an intermediate syndrome or an overlapping syndrome, where it can be called as intermediate syndrome, differentiating it from toxic epidermal necrosis. Next slide. So this patient is basically has a history of the one which I'm showing you has a history of Mycoplasma pneumonia infection very recently. So this patient presents to ED with complaints of this rash, the particular rash which I'm showing you. There is another one which I'm unable to unfortunately show you, where there is a maculopapular rash on the hands. Along with that, the slide B, which shows, these typical lesions, the rash with a middle, with the central part being a vesicle or a cyanotic region, the target lesion, and also the mucosal involvement. So this patient is erythema multiforme major, where the involvement of the skin was only 10%. This patient was first admitted in the hospital, resuscitated, or given basic treatment by IV crystalloids depending on the patient's volume status, and then IV steroids were given. After this, the patient was symptomatically better and he was sent home. Next slide, please. So coming to these diseases of erythema multiforme, SJS, and toxic epidermal necrosis, all of these three are basically more or less the same. The etiology, coming to the etiology, SJS is basically from the drug induced. Most of the cases I have seen, they were like only 3 or 4 cases I have seen, and among these, all of them were drug induced. And the most common causative drugs that cause SJS are penicillin, cephalosporins, quinolones, minocycline, and anticonvulsants like lamotrigine, carbamazepine, phenytoin, phenobarbital, NSAIDs, allopurinol, and even contrast medias. Paracetamol or acetaminophen also can cause SJS and TEN. Next slide, please. So infections which are commonly associated with the etiology of these conditions are Mycoplasma pneumonia, HIV, and herpes simplex, as we have discussed. It's genetic predisposition. These patients with SJS and HLA antigen allotypes were seen to have more, the genetic predisposition was more in few patients according to few studies, where the cytotoxic CD4 cells and HLA were involved. The pathophysiology is completely not understood as yet, but genetic predisposition was seen, and patients who presented with severe forms of Stevens-Johnson syndrome were asked to, not majorly here, but in few countries, they asked them to go for HLA prototyping to see if these patients are prone to SJS. So this patient is is another young female, as I told you. She had a rash on the face, mostly these erythematous papular eruptions. This patient had taken penicillin. So after that, she started to develop this rash, and fortunately, this patient presented early to the ED. That's when she was treated, and then this patient got discharged. Next slide, please. So coming to the clinical features of these patients, majorly these patients have prodromes of fever, myalgia, arthralgia, and few patients even presented saying there was generalized pruritus before the lesions even appeared, like burning sensation, and all of these did appear before the patients had symptoms of these. Next slide, please. So the lesions are typically maculopapular rashes and the target lesions. As you can see in this slide, the patient which I have seen is a 40-year-old male and had presented with maculopapular rash. And he was also seen having multiple regions of mucous membrane involvement as well, where his ophthalmic, oral, genital regions were also infected when he presented. So I shall discuss this case a little later, but this is basically the maculopapular rash and the target lesions which are seen in this slide, which are typical to SJS. Next slide. So this was the patient I was talking about, where the mucous membrane involvement is seen. The ophthalmic region here, the mucous membrane of the oral cavity was involved, and the genitalia of this patient was also involved. Next slide. So the management is basically coming to the history. You have to ask the patient if they had any fever, myalgia, arthralgia, if they had any, malaise, and we have recently been treated for any other infections with antibiotics, or are they under some medications for anticonvulsants or any painkillers as such. See, that is the main hint. Along with that, when you clinically examine the patient with associating with these, where the primary lesions are maculopapular, the target lesions, and also, as I told you, the involvement of mucous membranes, then we are very certain that we are dealing with SJS. And then to confirm, skin biopsy, histopathological examination can be sent along with the few bloods. And these patients, when you are suspecting SJS, do not send them home. Please admit the patient in ICU or in burns ward and then treat them accordingly. So prognostication is done by few scores called as Croton scale, and depending on their age and blood urea and other factors. This is one of the scales that is used. This is majorly done by the dermatologist. And the higher the scroton rates, the higher is the mortality rate. Next slide, please. So as we have discussed, if you know there is a causative agent like an antibiotic, please stop it first. That's the first step you have to take if you are able to identify it. Then next is resuscitation. Correct the hypovolemia of the patient. Ideally, crystalloid would be better. Then in these patients, you can see electrolyte disturbances. So please do manage the electrolytes fluid and electrolyte disturbances accordingly. Then manage the pain, pruritic rashes with diphenhydramine. And when these patients present with blisters and the bullae that are present, please treat them with the Burrow solution, which is 5% aluminum acetate with cold compresses. And steroids, yes, we are giving steroids right of now. IVIG can be given in these patients where the severity is high. And with steroids, there is a theory which is contraindicating, but in ER or when we are treating in ICUs, we do proceed with steroids. Next slide, please. So this SJS is basically found both in there is no sexual distribution or age distribution, but mostly this is seen in patients who are young, like 20 to 40. The next entity that I'm going to discuss about is toxic epidermal necrolysis. This is the most severe form of acute manifestation of acute severe form of dermatological conditions. So these patients, usually the mortality rate is 30%. This is the severe form of spectrum this is explosive dermatosis, which is characterized by tender nodules and erythemas. These patients have their mucous membranes involved, they are bullae which are formed, and there is extensive exfoliation. When you see the patient of a toxic epidermal necrolysis, you will very finely identify it because the amount of damage or the erythema and the bullae which are formed are extensive. As I told you, they are explosive, and the bullae which form actually do, separate the dermis and the epidermis. They enter between the region between the dermis and the epidermis, and they form the bullae. That creates complete sloughing and epidermal dermal region dislodgement. So patients are in with epidermal necrolysis are very ill. They are, as I told you, can you change the slide, please? The causative agents are usually drugs like penicillins, the same antibiotics that we have been discussing about, and then anticonvulsants. There was a patient who was a young female who was epileptic. She was on lamotrigine, which was started very recently. So this patient had complaints of fever, body pains since last 5 to 10 days prior presenting to the ED. And after this patient had come, we have seen her having the eruptive rash, which was seen all throughout the face, trunk, everywhere, the back. So when we took the history, she was started on lamotrigine, which was the reason for her TEN. These patients have genetic predisposition as well, and patients with idiopathic, they are patients who do not know the cause and idiopathic reason. So for these patients, unfortunately, the prognosis is really bad because we don't know the causative agent. Next slide, please. Next. So coming to the signs of TEN, it starts usually with warm erythema. Then that proceeds to, very ill-defined bulle, and Nikolsky sign is positive in these cases, both in SJS and TEN. What is Nikolsky sign? So basically to test, we press the lateral margin of the bulle where the epidermal fluffing is seen. And when you notice that, that is Nikolsky positive. Next slide, please. So as I told you, the lesions which occur in TEN are mucous membrane prone as well. So when they come onto your ocular, when coming to your ocular manifestations, they are purulent conjunctivitis, painful erosions, and these patients further proceed to potential blindness as well when it is TEN, which has been identified a little late. Anogenital lesions are pretty common. Along with this, respiratory tract and genital tract are also commonly involved. So basically, death in these patients is due to hypovolemia and electrolytic disturbance and secondary infections as well. So if you can deal with the hypovolemia status being corrected, the electrolyte disturbance being promptly attended, and only if needed antibiotics are given, that is when the patient can be treated very well. Next slide. Next slide, please. So as we have gone through, the causative agent has to be stopped, resuscitation based on the patient's condition, correct the hypovolemia status, fluid and electrolyte imbalance. Please address the pain because these patients are really painful. Really in pain, sorry. So admit them, treat them accordingly, include the burns team if necessary in the ICUs. And usually these patients do need parenteral nutrition, intubation, airway should be taken care of because when it further proceeds. And sometimes when these patients are presenting, they are already 24 hours, very rarely 24 hours is the time when they give you to treat. Sometimes they even go bad because the presentation takes, a week's time from the initial lesion to where the erosions take place. And if needed, treat the secondary infections aggressively, and IVIG can be considered in these patients. Next. So as I told you, the differentiation between SJS and TEN is the skin affected. When the skin affected is less than 10%, it is SJS, and overlapping sin or erythema multiforme major SJS and TEN overlapping syndrome is where there is 10 to 30% involvement, and more than 30% involvement is TEN. So the central location is with confluent blisters and papular erythema, which is present in SJS, with target lesions in either of those forms, the SJS and intermediate forms. But coming to TN, it is diffused exfoliative dermatitis. Coming to treatment, palliative care for all either of these manifestations with systemic treatment and topical and systemic in TN. So this was the case I was talking about. This gentleman is 40 years old with fever 5 days ago. This patient came to us after 5 days with rashes on the trunk. These were typical maculopapular rashes on the trunk and his hands. And when he came to us, he was typically looking like this with a rash on the back. When we took the history, he said he was treated with cephalosporins 5 days ago. And that was the reason for the SJS. This patient was treated with IVIG and the antibiotic was stopped, treated with the confluent medication. And this patient fortunately got discharged after a week. Next slide, please. So this was the young female I was talking about. She was on carbamazepine, which was the reason for TEN. This patient unfortunately wasn't well. Even after that, she had multiple infections and she succumbed. Yeah, thank you. Any questions?
Seems like we don't have any questions. Thank you, Dr. Priyanka. That was very informative, and I hope everyone will now understand there are few dermatological emergencies which are to be treated in time.
Thank you, Manvitha, and thank you everybody for your patience, and thanks for the opportunity.
Thank you.
Yeah.